As an industry leader in wound care, National Rehab is in a unique position to help enhance the quality of life for those with epidermolysis bullosa. With a team of specialists dedicated to serving EB patients and their families, our expertise not only allows us to identify effective wound care products, but also be a strong advocate in the relationship with insurance companies. The newsletter we've created, EB Advocate, is a trusted resource for families, and our website, ebnurse.org, allows you to connect with our insurance experts, product specialists, and other EB families. It's all part of National Rehab's belief that we're much more than a healthcare product company. We're partners in patient care.
Thank you so much, first of all, for inviting me to speak today. I'm glad to have the opportunity. I'm Kimberly Morell, a pediatric dermatologist from Columbia University, and we've heard a lot about the advances in the field of research in EB, advances in the field of wound care in EB. We're going to bring it back to some of the basics, because we all know we're here to find a cure for EB, but the reality is many of you are living with wounds on your skin every day, and you need to take care of them, and we need to do everything we can to help them heal better and faster and with less pain. So the items we're going to talk about today are, first of all, bleach. Next, we'll talk about vinegar. And finally, we're going to talk about honey, although I'm going to tell you a bit why we're not talking about supermarket honey on your wounds, but rather this medical grade honey. So why is wound antisepsis important? I just want to give you a little bit of background as to why. First of all, if we took everyone in this room and I went around and took a culture from your nose or your skin, there'd be bacteria living there. They're ubiquitous. They're a normal part of our lives. The problem is when they start living in your wound, they are associated with delayed wound healing. That is not good. And even when there's not a clinical sign of infection, that, as Dr. Arbunkel mentioned, that burden of bacteria in the wound interferes with wound healing, and the more organisms we have are also not good for your wound. So we should all know what signs of a wound infection look like. You have a pain, warm, swollen wound with redness around it, a red or pink streak coming up from that wound, possibly with pus, possibly with fever, ill appearance. These are all signs of a wound infection. Go to your doctor. But even when you don't have these physical signs of infection, having a lot of bacteria in your wounds is not a good thing. It can lead to superficial or localized skin infection when you have a certain amount of bacteria there. Certain bacteria, even in small amounts, they're not good to be living on your wounds. We want to get rid of them. Again, locally they can cause localized infection. In worst case scenario, these same bacteria living on your skin could potentially cause infections in your bloodstream and sepsis. So all the more reason to get things under control. So what bacteria live on our wounds? We know what we see commonly. We know we see staph and Pseudomonas, and actually this study looked at adults with chronic leg wounds and found the most common bacteria that were living or colonizing wounds were Staph aureus, Staph epi, and Pseudomonas aeruginosa. So we actually asked the question at our center, what are some of the common bacteria living on our patients' EB wounds? And actually our fellow took a look back at this question. And so we looked back at 10 years, 30 of our patients, looked at all their cultures, found over 200 positive cultures, mostly from their wounds, a few blood cultures and nasal cultures. And here are the data. I'm not going to spend time on this slide, but just to summarize, similar to what we see in chronic wounds, we see a lot of patients, most of them had Staph aureus, sensitive strains of Staph aureus, but a couple of them also had resistant MRSA. Strep, diphtheroids, and then Pseudomonas and yeast were other fairly common bacteria and yeasts that were found living in and on the wounds of our patients with EB. So, also, more than one bacteria. Almost half the patients had more than one type of bacteria. A small amount had 4 or more bacteria from those wound cultures. Not a good thing. And so what do we do about it? First of all, we know what we do when we have an infection. Those signs we talked about, you go to your doctor, you're going to get antibiotics either by mouth or intravenously and do your topical wound care. Now, when you're colonized, this is more of an issue because antibiotic resistance to topical antibiotics is on the rise. And as Dr. Arbuckle mentioned, there's a risk of contact dermatitis to what we're putting on our open wounds and open skin and absorption of these agents that we're putting on our skin, so we have to be careful. And just some more evidence about that mupirocin resistance on a rise. This study from 1990 actually looked at EB patients using mupirocin on their open wounds. And yes, the patients reported less pain and better wound healing, but a few of the patients did have mupirocin-resistant strains of Staph aureus, so let's watch out for that. And then more recently, there's actually an article from Canada that talks about a 50% rate of mupirocin resistance in Staph aureus. That's pretty scary. And when we talked to our colleagues in New Zealand, where mupirocin is over the counter, mupirocin-resistant Staph aureus is actually quite common. So, what can we do about it? That brings us to the first item on our grocery list, which is bleach, which is chemically a 6% solution of sodium hypochlorite. And raise your hand if you've heard of dilute bleach baths. Good. How many of you have taken a dilute bleach bath? Yeah, so a good number of you have done it or heard about it. And, some of our patients, when they first hear about this, say, you want me to do what with what? This is that stuff that I keep in my, child-proof cabinet that has a Mr. Yuck sticker on it. What do you want? What are you talking about? Well, yes, there are risks to bleach. We know it can fade our clothes when it splashes on them, and it can do things to our hair, like make it go from this picture on the left to this picture on the right. But getting serious about it, bleach does have risk. In its direct, concentrated straight from the bottle form, it can cause irritation, chemical burns, harmful if swallowed, harmful if you inhale it. Don't get it in your eyes, right? It's a chemical. But it does have some good properties too. We know that in its straight form, this is from the Clorox website, kills lots of bacteria. There's that staph, that Pseudomonas, just about every one of those bacteria and yeast on our list of the common things living on our patients' EB wounds, it kills. So where did the history of bleach for use on wounds come from? It dates back to World War I. It was commonly used as an antiseptic in a diluted form, 0.5% sodium hypochlorite to treat war wounds, burn wounds, etc. And be antibacterial. Now, the problem is some later studies in the 80s started coming out showing that it wasn't so good for the skin cells. Yes, it killed the bacteria, but it was toxic in this concentration of what's called Dakin solution, this 0.5% solution, not so good for putting on open wounds, right? So some more research was done, and actually some doctors found that even a very low concentration of bleach killed bacteria without harming those fibroblasts or those cells that you really need to help be present to heal your wounds. This is just a picture from that study. Here's that Staph aureus bacteria in water, and here it is in contact with that 0.005% concentration of dilute bleach. Bacteria are dead. So the exact dose of what we use, we still don't quite know. This is another study from the lab, and also they used in animal models to look at wound care. Their recommendation was a 0.025% dilute bleach preparation, which killed the bacteria but didn't harm the skin cells. And this has been called modified Dakin solution. So where is our evidence base for using it in EB? Well, the best we can do is we can point to an article actually on our patients that we use dilute bleach baths for commonly, and that is patients with eczema and a history of skin colonization or infection of Staph aureus. This study by Dr. Taller's group, who will be here later tomorrow, I think, to talk to you about some other genetic aspects of EB. She was in charge of this study where they used dilute bleach baths, intranasal mupirocin, and did find that in their eczema patients who bathed in it, they had less clinical severity of their eczema and fewer secondary bacteria